Hello, my name is Stephane Borentain. I am the Global Medical Affairs Lead for Esketamine with Janssen Medical Affairs. My disclosure, sponsorship for this study and preparation of this poster was provided by Janssen Global Services. I am an employee of Janssen Global Services. On the behalf of my co-author, it is my pleasure to present our poster describing the relationship of sleep disturbance to the antidepressant effect of esketamine and vice versa, based on post-hoc analysis of pooled data from two pivotal phase 3 trials of adults with treatment-resistant depression. During our discussion, when I reference esketamine, I am referring to Spravato nasal spray, which is indicated in conjunction with an oral antidepressant for the treatment of treatment-resistant depression and for the treatment of depressive symptoms in adults with major depressive disorder in a psychiatric emergency. Transform 1 and Transform 2 were similarly designed 4 weeks, double-blind, active-controlled, multi-center trial of esketamine nasal spray in outpatients with treatment-resistant depression. After screening, adults with moderate to severe depression and non-response to at least 2 but no more than 5 antidepressants in the current episode were randomly assigned to receive twice-weekly esketamine nasal spray or matching placebo nasal spray, each in combination with a newly initiated open-label oral antidepressant taken daily. Independent, blinded remote rater performed MADRS assessments via structured interview at baseline and all post-baseline visits during the double-blind treatment phase. Sleep disturbance was evaluated using MADRS item 4, assessing perceived reduction in duration of or death of sleep versus patient's normal pattern when well. Using this item, score 0 to 1, 2 to 3, or 4 to 6 indicated absent or slight, mild, or moderate to severe difficulties respectively. As you can see in Table 1, most of the 565 randomized patients in both groups reported disturbed sleep at baseline, approximately 2/3 having moderate to severe disturbance. Figure 3 reveals that a higher proportion of esketamine-treated patients achieved response and remission at day 28 compared to antidepressant plus placebo, regardless of the presence or severity of sleep disturbance. Consistent with this, Figure 4 reveals that sleep improved in both treatment groups after the first dose of study drug on day 2, significantly more so with esketamine by day 8, a difference that persists through day 28. In line with this finding, at day 8, more patients in the esketamine antidepressant group versus the antidepressant placebo group, 26.1% and 15.7% respectively, achieved clinically meaningful improvement in sleep, defined as a more than 2-point decrease in MADRS item 4 score from baseline. This improvement increased over the double-blind treatment period, reaching 49% versus 41.4% respectively at day 28. The limitation of this study: our results are based on exploratory post-hoc analysis of MADRS item 4. Other standard clinician-reported instruments to report sleep disturbance were not performed in the Transform studies. Patients more than 65 years old, those with moderate to severe substance or alcohol abuse, and those taking high dose of benzodiazepine were excluded from Transform studies. Finally, this study did not include objective measures of sleep such as polysomnography. Taken together, our results support the antidepressant efficacy of esketamine nasal spray in patients with treatment-resistant depression, regardless of the presence or absence of sleep disturbance. 1 week after the initiation of treatment, more esketamine-treated patients reported clinically meaningful improvement in sleep than those taking oral antidepressant plus placebo. Additional research using objective marker of sleep and established clinical assessment tool of insomnia will expand upon this finding.